Hey everyone, Dr. Matt Geller here. Hope you enjoyed that short break. I know everyone is watching some great content. What do I have behind me? Looks like maybe some MIGs and some new studies coming out. We've got all this track streaming here. Hope you're enjoying it. This talk is very special. I've got Dr. Bita Asghari, super excited for this one, and we're talking glaucoma in the scleral lens practice. Let's bring her on. Hey, how are you?
Hi, I'm doing great, Matt. Thanks for having me.
Absolutely. Thanks for being part of it. Let's jump right into it. I'd love for you to just share more to our viewers about a little bit about yourself. You have a super unique background, and
Sure.
it's great to see kind of your journey.
Sure, thanks. So I'm a graduate of Southern California College of Optometry at Marshall B. Ketchum University. I went on to do a residency in contact lens and ocular disease at the Ohio State University Havener Eye Institute. From there, I was fortunate enough to get connected with the people of Boston site, where I've been at that clinic now in the organization for coming up on 4 years. We are a scleral lens organization focusing on what you may have, some of you out there may have heard called PROS treatment. And we focus on seeing patients who are referred to us with advanced conditions, from corneal ectasias to trauma to ocular surface diseases. And what we do is we fit them with scleral lenses to help improve their quality of life. We're also a nonprofit organization. All that to say, we are very firm on our educational initiatives. So I'm fortunate enough to also be an adjunct faculty for MCPHS and NECO as well. So there I serve as the Associate Director of Clinical Education while seeing patients full time. And on the side, I get to do fun things like this.
There you go.
Thanks.
Right on. The most fun thing right here.
The most fun thing, that's right.
Thank you. No, that's really incredible, and congratulations on all of this success. And you're just getting started, so definitely one to watch right here for all those tuning in. One to watch, Dr. Asghari. Let's jump right into it. I know that specialty lens clinic, specialty lenses as a specialty is certainly on the rise. It's, I think, rated in one of the surveys as the #1 specialty of interest, even above ocular disease, which is kind of a surpriser. But, when thinking about specialty lenses and glaucoma, what's the association? How do these two fit together?
So it's something that I think is gaining a lot more traction in recent years. And with the increased utility and popularity and accessibility of scleral lenses in general, I think we need to start looking at this a bit more closely. So the association, the indications for scleral lens wear is anything from improving vision, improving comfort, or supporting the ocular surface in patients with irregular corneal shapes or ocular surface disease. So we're thinking patients who've had corneal transplants, we're thinking patients who may be aphakic from trauma, patients who have limbal stem cell deficiency, what have you. And all these conditions that I just mentioned have a strong association with glaucoma. So it's really important, if you are in a scleral lens practice or you want to become more involved in the specialty lens world with scleral lenses, to be mindful of the associations here. And that's what I hope this talk here will kind of serve as, is to broaden the understanding and answer some questions which maybe people may not have even thought about.
Yeah, for sure. So, maybe the first thing that comes to mind, you're putting a scleral lens on the eye. Does that impact IOP? I mean, it's not a microkeratome being placed on there, but when thinking about that, is that a concern? What if you have a delicate glaucoma patient?
So that is a $1 million question that people in industry and researchers are trying to answer. There have been, this question has been raised decades past, and just in 2020, there was at least 4 different publications that came discussing potential association with IOP and scleral lenses. I will tell you, the verdict is still out there because some of these studies, it's difficult to measure intraocular pressure accurately while you have the lens on the eye. And in addition to that, it's even more challenging to monitor true optic nerve function and do visual fields and OCTs, et cetera, to really see if there's an association. So it's something to watch. The verdict is still out. There's some conflicting literature which says there is an association, and there's other literature which says there isn't. And there's also the question of, how does a scleral lens fit impact that? It could be that if it's fitting appropriately, it doesn't affect it at all. So to be continued.
Yeah.
And yeah, lots of research in the pipeline right now.
So I guess, and maybe this is maybe this is an unfair question, but like if you had a really delicate glaucoma patient, would you at this point be a little more weary of fitting them into sclerals, or is it really just a risk benefit, right? They totally need them. It's like, all right, of course we're going to fit them in this, even if there is an IOP increased risk, or what should a doc think about until the research is more conclusive?
That's a great question. And I will say my clinical practice of myself and my other colleagues who are in our organization as well has really not changed with this literature because nothing concrete has really come out.
Got
I
it.
will tell you the patients who do benefit from scleral lenses at any point, whether they have glaucoma or not, we have to assess the risk and benefit appropriately. If somebody needs a scleral lens and they failed everything else, then the indication is there. So we ask ourselves, should we hinder or prevent fitting patients on a possible impact in IOP? And since we haven't seen the association and decades worth of patients have not developed glaucoma or lost vision, then for those reasons, we haven't stopped.
Got it. Yep, that's very fair. Makes sense. Now, let's talk topicals and sclerals. So, we just were reading in our past interview that the most recent 2021 glaucoma report we did, which was 667 ODs across the United States, said that topicals, 84% said topicals were their primary treatment regimen. And so I'm sure that some of those patients have sclerals, and of course it's something to be plugged into. So can you enlighten us there and shed some light on just topical medications if you're currently in sclerals or thinking of put a patient in sclerals?
Sure. So topical medications, I think a lot of them obviously have preservatives, and prostaglandins and glaucoma medications in general can be pro-inflammatory. So sometimes when you have these patients who already have ocular surface diseases and wear scleral lenses, two things can be a bit difficult with taking these topical medications. One is the frequency of the dosing. So if they are taking it more than twice a day, then that may be very difficult for them. Second would be the fact that these preservatives can be really impactful and harsh on the ocular surface, which can make it more challenging for patients to tolerate wearing their lenses because their conj is hyperemic, they're inflamed, etc. So consideration should be given to possibly laser treatments, and surgical approaches can be a little bit tricky, but we can talk a little bit more of that coming up.
Got it. And so that's interesting because, in some of the previous talks, or at least just throughout the show today, we're learning a lot about SLT as a primary therapy, MIGS, early intervention with MIGS, and so potentially that could benefit the scleral lens patient, right? So you're not having to worry about the topical side of things, or at least delay the worry for the topical side of things. But this next one here, I've got a good one, fitting challenges to consider in fitting patients with glaucoma surgery or who have had glaucoma surgery recently.
Sure. So the challenge, the scleral lens fit is to be aligned on the conjunctiva. And what happens if you have a trabeculectomy or some type of tube shunt place, you now have an irregularity on the conjunctiva, it's elevated, and that serves as a literal obstacle of trying to get a piece of plastic, like a large diameter scleral lens, to lay over adequately over that contour, that elevated area. So that can be very challenging in scleral lens patients. I will say, very commonly in our practice, if we have somebody who is functionally dependent on wearing their lens and they have glaucoma, they're considering having surgery, oftentimes we will make our recommendations to the surgeon, we'll get on the phone and talk to them about the logistics of candidacy after they have surgery. So we talk to them and say, hey, is there any way we can take a pars plana approach so that the tube is not going through the limbus into the anterior chamber, because that's such a close proximity to the cornea. So in any way, if we can get this type of conjunctival elevation or obstacle to be more posterior on the ocular surface, we like to do that because it just makes the possibility of fitting so much easier. With that said, there are plenty of other things you could do to try and fit around an anatomical obstacle. You could put notches, you could put channels or things to elevate over it. But if you have a huge bleb or a huge tube shunt that's in very close proximity to the limbus, that makes it a lot less likely for the eye to be fittable.
Yeah, no, I love this topic, and it's probably something that goes overlooked because You know, glaucoma surgery is different than, say, cataract surgery, so they're not cranked out as fast or as many, but they're very common. And so any just co-management tips there, I know you're at a, you know, a significant center that maybe has better processes in place, but, you know, just say a doc's fitting sclerals here and there, and, you know, let's say they're not dealing with the glaucoma care for a particular patient. How can they just like better make sure that they're involved in that, even before the pre-op? You know, how can they get their footing in there to ensure that the surgeon knows about this situation? Is it more of just patient education at that point?
So ideally, we would be able to have more discussions like this and have all the glaucoma surgeons join us on this. That's a thought, Matt. But in all honesty, what we do is we empower the patient with the knowledge.
Right.
And I always tell them, I say, anything that changes with the structure of the eye, if anything changes with your lid anatomy, there could be anything with surgery, period, could affect your fit of the lens, which could affect your candidacy to continue to wear the lens. So I tell them all the time, you got to communicate with me, ask them to send the records, ask them to pick up the phone and call me. If you ever have a question, you call me and I'm happy to talk with you and guide your surgeon or your doctor in the right direction. Because the fact of the matter is, this is an overlooked kind of an issue. And oftentimes we can't do anything about it once the surgery's been done. Yeah. And in hindsight, we just wish we could talk to them. So empowering your patient with the education and that knowledge, I think, is the most powerful thing you can do, because then you're putting the responsibility in their hands to make sure everyone on their eye care team is coordinating their care appropriately.
Yeah, no, really, really solid points. Other clinical pearls around glaucoma and sclerals. I'm sure you've seen some really interesting cases and have given plenty of advice to other docs out there. What else can we keep in mind as optometrists?
So one thing, if they are on topical medications, absolutely right up front, set the expectation that they are susceptible to redness even with lens wear. A lot of patients have ocular surface disease because of their glaucoma medications, and they may not have alternatives. And we're there to tell them, hey, this lens will help you feel better, you may see better, but the redness may not go away. That's one. Two is you always want to check the pressure at baseline, and you check it at every visit. And this is particularly important for patients who have surgery, who have a bleb or a tube shunt, and you have a lens that's resting over that area, because you want to make sure that the drainage device is still functioning appropriately and the lens is not landing on it in a way that compromises its efficacy. Yeah. And the third thing I will say is whenever you see corneal swelling after you remove a lens, which you should always remove a lens for all of your patients when you're doing your complete fit assessments to see how the eye is responding. If you ever see corneal edema on the eye, especially bullous edema, you should check the pressure, because there is an association between corneal edema and elevated IOP. Because when you have an elevated IOP, we know that compromises endothelial cell function, which compromises its pumping effect, which can then lead to edema. So those are some of the biggest clinical pearls. I could go on and give a whole lecture on this, but those are probably the most important things to remember.
Yeah, really solid points. Honestly, this particular interview makes me miss patient care. So
come visit us anytime.
I can come back. I think my team would be really, really mad at me, but I don't think I could do that to them. But yeah, no, this is really, really solid, and I'd love to turn this one into an article. It's phenomenal, really good advice, and I think just a topic of further discussion. And for some of the diagnostic companies out there, I think there's a challenge that needs to be conquered here of measuring IOP with sclerals and other contact lenses for sure. There's a whole area to pioneer there.
Exactly. Yes, there is.
Yeah.
More to come.
More to come. Dr. Asghari, I really appreciate it. This was incredible, and I hope you enjoy the show, get some CE. And for everyone out there, I'll be doing more interviews here in the exhibit hall. Do check out the conference bag. We're donating $1 on your behalf to Optometry Giving site. You can download the 2021 glaucoma report, which I've got here, and some other really cool backgrounds, wallpapers, things like that. And hope you're having a great time at the show. Dr. Asghari, once again, appreciate it. I'll check you soon.
Thanks for having me.
Absolutely.
All right, good luck. Have fun, everybody. Bye-bye.
Bye, everyone.